Fantastic. So what I'd like to talk to you guys about today is essentially endodontic disease. And I want you to take a few very specific messages home. I want you to be able to explain to your clients what is endodontic disease and why it's a problem and why it's not something that should be left. I want you also to be able to diagnose endodontic disease, categorize it, radiograph and evaluate those radiographs and be able to describe what you're seeing to your patients, sorry, not your patients, your clients, and then make recommendations whether or not they be in-house or whether or not they be referral-based. So to do that, we kind of have to go through a little bit of boring stuff, and that's mostly dental anatomy. So we're going to start off on the outside of the crown, and you can see that that's the enamel. I'm sure you're all aware of what that is, so I won't go into too many details. And then we've got the second layer, which is the dentin, and then the inner layer, which is the pulp itself. And the pulp is actually a very specialized tissue. It contains blood vessels, it contains nerves, it contains connective tissue, and then on the very periphery it has a layer of odontoblasts, which are actually the most important cell within the tooth because they actually produce new tooth structure or new dentin. And towards the root of the tooth, we've got an apex. And in dogs and cats, we have a delta, which is lots of little channels leading into the periodontal ligament and the alveolar bone. We've got a fair bit of alveolar bone. And then on the outside of the alveolar bone, we have the soft tissues of the oral cavity. So we've got alveolar mucosa. Sometimes there's skin, there's nasal cavity. And that sort of space where there's alveolar bone between the external soft tissues, that becomes clinically relevant when we talk about the pathophysiology of endodontic disease. So the definition of endodontic disease is the infection or inflammation of the pulp of the tooth, and there are a variety of causes. The most common causes in dogs and cats is trauma, so dental fractures, concussion, which is low-grade trauma that doesn't result in damage to the tooth structure itself. Jaw fractures can also cause endodontic disease, and the way that this occurs is that when we fracture a jaw, oftentimes we're disrupting blood supply to the apex of the tooth, and subsequently the tooth dies due to that. Gum disease can also cause endodontic disease, and caries or cavities are the most common cause of endodontic disease in people, but thankfully they only have a prevalence of about 4% in dogs. So when we talk about tooth fractures, I'd like you to be able to recognize the 7 different categories of tooth fracture. So we have things as mild as enamel infraction, which are these minuscule small cracks in the enamel itself, all the way through to loss of a piece of enamel, loss of a piece of enamel with dentin, or what we call it uncomplicated crown fracture, and then a complicated crown fracture on the very top right here where we have exposure of the pulp. We also discuss root involvement, so we can have root involvement and the crown involvement without exposure of the pulp, what we call an uncomplicated crown root fracture, or UCRF in the bottom left corner. We can have a complicated crown root fracture, or CCRF, and we can have a root fracture, or a fracture of the tooth structure that is wholly ensconced within the root itself, on the bottom right. So how does this cause a problem? So the way I explain it to my clients is that, first things first, we see a damage to the crown. And then almost immediately we see bacterial contamination of the pulp. And then what happens is that this causes pulpitis, which results in pain. And then gradually what we see an encroaching infection and encroaching inflammation towards the apices of the teeth. And this results in pulp necrosis. So when the nerve dies, when the pulp dies completely, the pain stops because there's no more any nervous stimulation. But because it's a contaminated sort of soup-like necrotic focus, what tends to happen is you have leakage of bacterial byproducts such as lipopolysaccharides into the surrounding tissue, and then this secondary wave of inflammation almost causes pain. Now, one of the things that I would like you guys to take home is to not refer to these periapical pathologies as abscesses. And the reason for that is because an abscess is a histological diagnosis, and it's defined as a pus-filled cavity, whereas in reality, most of these lucencies are actually granulomas. And sometimes we see cysts, and sometimes we see abscesses, and they can all cause discomfort, but the term tooth root abscess is actually a little bit of a misnomer. So what about these guys? What about these uncomplicated crown fractures? How do these cause inflammation and potential discomfort. So the first thing I'd like you to do is make sure that you can confirm that this is truly an uncomplicated crown fracture. And the easiest way to do that is to use an endodontic explorer or your shepherd's hook. And if it is a pulp exposure, what you'll see is you'll see the shepherd's hook penetrate into the pulp cavity itself. Sometimes that pulp cavity can be obstructed by calculus, and what I'll often do is I'll actually use the tip of my ultrasonic scaler on a low power setting and scale around the suspected pulp exposure, and if I can keep chipping away at it, that typically means that that's a pulp exposure that's filled with chronic calculus formation. But when you do identify a true uncomplicated crown fracture, it's important to tell the client that these can potentially cause problems depending on a variety of factors. So it all comes down to the structure of the dentin. So dentin is actually quite porous. It's kind of very similar to a sponge. It's got little tubules running through the width of it. And these tubules actually have cellular processes called odontoblastic processes that actually extend into the tubules. So how does this cause pathology? Well, these tubules are also filled with fluid, and when you have exposed dentinal tubules, that fluid gets exposed to changes in temperature, and that causes the fluid to expand and contract. Now, because the fluid, as it's doing this, is actually pulling and pushing on those odontoblastic processes, and these odontoblastic processes are often entwined around nerve fibers, you tend to see stimulation from that stimulus that causes this discomfort. It's what actually causes our tooth sensitivity to hot and cold foods and to air blowing across the surfaces of the teeth. That typically means that you've got exposed dentin. So as I mentioned, dentin is porous. On the right side, you'll see an electron micrograph, and you can actually see the bacteria on the surfaces of the dentin here. You can actually see bacteria within the dentinal tubules themselves. Now, in a living tooth, this is not a concern because those odontoblasts also produce fluid, and this fluid tends to flow outward, so it tends to push the bacteria out. But when the odontoblasts die, that no longer occurs, and that allows the bacteria to potentially invade into the pulp cavity once the odontoblast dies. So, exposed dentin causes damage or irritation to the odontoblasts. Those odontoblasts may die. And if enough of them die, what tends to happen is that the pulp doesn't recover. If a small area of odontoblasts dies, the pulp has the capacity to form stem cells, and those stem cells differentiate into new odontoblasts. But if enough of the odontoblasts are damaged, then what happens is that inflammation progresses through to pulp necrosis, and that leads to periapical pathology. So the outcome really depends on the extent of the fracture. So the larger the area, the more odontoblasts get affected, as well as the distance from the pulp, because if the distance is really short, then you've got a shorter distance for bacteria to migrate into the pulp cavity. So next, after fractures of teeth, we want to talk about tooth discoloration or concussion. And it's important to differentiate between extrinsic discoloration, which is due to external sources, and intrinsic discoloration, which is changes in color to the tooth structure itself. And this is really what we're concerned about. So there are a couple of different causes of intrinsic discoloration, but really the most important one is the pulp or pulpitis or pulp necrosis. Now, how does this occur? How does irritation or concussion to the pulp cause discoloration? So as you know, pulp is full of blood vessels, and when you have concussion to the tooth itself, you can have leakage of red blood cells into the connective tissue. When those red blood cells die and break down, the hemoglobin byproducts actually leak into those porous dentin, particularly if the odontoblasts have died and have vacated those spaces. So what happens is that initially you see a pink color because that's the original color of hemoglobin, but as it starts to break down, it becomes purple, followed by gray, and occasionally we see a dark brown color. So it's important to note that this discoloration is actually baked in almost into the tooth structure itself. So even though a client might present to see you for a discolored tooth, it's really important to tell them that even though we might have to deal with the tooth, we're never going to be able to remove that discoloration unless you want me to bleach a tooth. which I won't do because it's a purely cosmetic issue. So another question that often gets asked for me is that, well, if the tooth structure is intact, then even though it's necrotic in terms of its pulp, it's a sterile necrosis because it's not exposed to the oral cavity, and therefore it's not going to get infected. Well, I can see where they're coming from, but what we do know is that even with intact tooth structures, we sometimes see infection of the pulp. And the way that that occurs most commonly is that actually occurs through micro cracks in the tooth structure. So if you remember that very minor category of tooth fracture known as enamel infraction with the little cracks, so that's actually how bacteria get into the pulp once it gets to that point. We used to think that infection in intact teeth used to come from bacteremia, and that was proved in a way by someone injecting a large amounts of bacteria into the bloodstream and then culturing the tooth structure. But what we know is that that was purely artificial, that was purely a very specific scenario, and that typically doesn't happen in real life. So the other thing that people often ask me, well, how do we know, and what percentage of these teeth are really a problem? What percentage of these teeth actually have pulp necrosis or pulpitis? And we know the figures based on a study by Dr. Fraser Hale from Canada. And essentially he looked at a bunch of teeth, and it was fairly crude the way he looked at them. He just cut into them and pulled out the pulp and had a look at it grossly. But what he found was that 92% of these teeth actually have either irreversible pulpitis or really inflamed pulp, or they actually had pulp necrosis completely. So the vast majority of these teeth, in dogs at least, are dead or dying. And what he also found was that 43% of these teeth did not have any evidence of endodontic disease. So based on radiographs alone, we can't really tell. So when we see a discolored tooth, even if we took an X-ray, the likelihood is that that tooth is in trouble. Now, another question that I often see is, well, he doesn't seem to be uncomfortable. And the way that I try to explain the situation to these clients is that we know from human dentistry that pulpitis is painful. And we know that once a pulp exposure has occurred, or once a discoloration has occurred, that the patient has pulpitis. And that when there is active pulpitis, there's pain. Once the pulp dies, then even though there's no pain, there's always a potential for infection because it's a focus of necrotic material. There are also no good pain scoring methods for oral pain in companion animals. The companion animals also tend to hide their oral pain really, really well. They don't tend to limp on their mouths, is what I usually tell my clients. And a lack of clinical signs does not necessarily equate a lack of pain. And the reason for that is because we know that the physiology and nociception is very similar in companion animals when compared with people. Lastly, what I often tell my clients is that infection needs to erode through a fair amount of alveolar bone before it's detectable as a facial swelling. So that patient might have a great degree of infection or long-standing infection before even the facial swelling occurs. And if we just evaluate these patients based on clinical criteria, we're going to underestimate pathology. So the next best thing we can do is really take an X-ray. And to do that, we should probably talk a little bit about normal endodontic anatomy. So this is a radiograph of a right maxillary canine tooth. The patient's nose is to the right of the screen, and the caudal is to the left of the screen. And what we have here on the outer layer, the white material, that's the enamel. And then we've got dentin, and then red pulp. And then around the periodontium of the tooth, the periodontal ligament is the black line. And then I want you to pay close attention to just outside of that black line, there's actually a fainter white line, and that is what we call the lamina dura. So the lamina dura is the alveolar cortex. So each alveolus has a thin layer of cortical bone, and that's actually what the lamina dura is. That black pointy thing, that's actually a Chevron Lucencies. So that's just a thickening of the periodontal ligament at the apex of the tooth where the blood vessels enter the tooth. And it's a structurally normal entity in certain teeth. Lastly, we've got trabecular alveolar bone and cortical alveolar bone on the more coronal aspect of that tooth. So there are four main signs of endodontic disease that I would like you to recognize. And the way that I was taught to teach this is, think of it as a sequential manner. What happens first? So what typically happens first is some sort of trauma to the crown surface, right? So when we see a disruption in the crown structure, we tend to term that a loss of crown integrity. And then what happens next? Well, typically the pulp dies at some point. So when we see pulp death, what happens is that cavity never gets any narrower. As you know, as a pulp matures, as a tooth matures, the pulp cavity gets narrower as the tooth puts down more dentin. And when this is stopped, what we tend to see is a pulp cavity that's a little bit wider. Next, we see a periapical lucency. When we have bacterial breakdown products and chronic inflammation around the apex of the tooth, the first thing that gets resorbed is bone. And after that, if we have a long enough standing inflammatory process, the other thing that we tend to see is inflammation of the root apex. So that green line is just a point of reference to show you that there's been shortening of the apex of that right mandibular canine, which is this guy here. You can see the apex is a little bit shorter. And if you look closely, you can see that the apex of this tooth is a little bit irregular as well, and that's due to inflammatory root resorption. So just to reiterate, first thing is loss of crown integrity. Second thing is failure of the pulp cavity to narrow. Third thing is periapical lucency. And lastly, inflammatory root resorption. And the most important ones are the ones that I tend to rely on is the failure of the pulp cavity to narrow and the periapical lucency. Those are the two things I typically look for first and are most consistent. So there are a couple of things that can mimic periapical lucencies. So on the top left here, I apologize for not orienting you more carefully initially. So on the top left of the screen, we actually have the left mandibular canine. On the bottom left, we have the right mandibular canine, which is the one with the true periapical lucency. And on the right, we have an occlusal view. So on the occlusal view, the right mandibular canine is on the left, and the right mandibular canine is on the left, and the left mandibular canine is on the right. So I'll just bring your attention to the top left, or the left mandibular canine. You can see that there is a lucency at the apex of that tooth. It's right here. But that is not a true periapical lucency. And the way that we can tell that is if we actually have a look at the shape of that lucency, it tends to follow the existing alveolar cortex. It looks like an extension of that alveolus when you look at it in relation to the apex of the root. Whereas if we have a look at the right mandibular canine in the bottom left, we can see that we have a lucency that's way more bulbous and way more poorly defined. Okay. So this is another example. On the left of the screen, we have a normal mandibular first molar. In this case, it's the right mandibular first molar. Okay. We have Chevron Lucencies there as well. Oops, sorry. And they follow the existing contour of the alveolus. And on the right, we have a mandibular first molar with large periapical lucencies. And you can see that they don't follow the existing contour. The third category of teeth that tend to have Chevron lucencies are the maxillary incisors. And if you have a look at this radiograph, you might think, oh my goodness, there are periapical lucencies associated with each of those incisors. But when you have a look at the contour, you can see that they all tend to follow the contour of the alveolus quite well. So what are Chevron lucencies? Chevron lucencies typically follow the contour of the existing alveolus, and what they are is they're just the thickening of the periodontal ligament in an area where the blood vessels enter the tooth. They're typically pointed, and they typically involve specific teeth, so the canines, the carnassials, and the maxillary incisors. The periapical lucencies, so that's a Chevron lucency. That's the diagram that I typically use. So they are an upside down V and they're pointy at the end. So periapical lucencies, they don't follow the contours of the existing alveolus and they're typically a little bit more rounded. And the analogy that I like to use is they look like a lollipop on the end of a stick. So if you see a lollipop on the end of a stick associated with one of your root apices, that's a true periapical lucency. So the second imposter here is typically located in the rostral mandible and typically located apical to the first and second premolar. So Oopsie, it happened again. So you actually have a look at this little lucency here. It appears to be a lucency associated with the mandibular first incisor. So just ignore this root canal tooth there. So this is the canine on the right. This is the right maxillary first premolar. This is the right maxillary second premolar, and this is the third mandibular. And this is the third mandibular premolar on the right side. And this is the lucency there. But what we can do is we can actually change the radiograph, the angle of that radiograph, and you can see that the lucency moves away from the apex. So you know that it's not a true periapical lucency. And what these lucencies are, this is the second one here, as you can see, just apical to the third premolar. What these lucencies are they're actually mental foramina. So the mental foramina, the rostral mental foramen, is apical to the I2. The middle mental foramen is apical to the P1 to P2, and the caudal mental foramen is apical to P3, and these tend to mimic periapical lucencies in these teeth. So what strategies can we use to identify these imposter teeth, so to speak? Firstly, look for clinical evidence of endodontic disease. So if there is clinical evidence of endodontic disease, then regardless of whether or not it's a true periapical lucency, then that's clinically significant. But if there's no evidence of endodontic disease clinically, then we should look a little bit harder. And we do that by fractures, discoloration, periodontitis. We can do that by changing the angle of the radiograph and seeing whether the periapical lucency moves away from the apex of the tooth in question. We can radiograph the contralateral tooth and compare left versus right. And lastly, we can repeat the radiograph in 6 to 12 months if we are really, really not sure. The other thing you can do is you can send a radiograph to me for teleradiology, but these are the other strategies I tend to rely on first.
Hey Kevin, it's Zoe here. Someone's just commented there's a slight delay in what you're saying in your slides. So would you mind just slowing down a little bit between slides?
Sure.
Okay, no problems.
Thank you. So let's talk about treatment options, and there are a couple of things that we should probably consider. So we should consider client resources. So can they afford the treatment options that we are recommending, either from a financial point of view or from a need for multiple anesthetics? Can the patient afford the resources? Is a stable patient under anesthesia? Are the clients willing to follow up in terms of follow-up radiographs, for example? What are the patient's chewing habits? Is it a really destructive dog? Is it likely to refracture that tooth? What is the tooth involved? Is it an important tooth? If it's not an important tooth, does the patient have a specific function, such as either an agility dog that requires a lot of catching, or alternatively as a show dog that pretty much needs full dentition? So all of these things are things that we should consider carefully and take into account when we're recommending and presenting treatment options. So I'm sure you're familiar with all of them. We've got root canal therapy, we've got vital pulp therapy, which are two different types of endodontic therapy. We have extraction, which I tend to think is a salvage option. And we have odontoplasty and dentin bonding, which is something that we use for minimally fractured teeth or those uncomplicated crown fractures. The other thing to take into consideration is the overall health of the tooth. Does the tooth have any problems? There is no point spending lots of money on a root canal treatment if the tooth is mobile and about to fall out due to gum disease. If the patient is a bad chewer, something else that we might consider doing is putting a metal crown on the tooth to prevent any further damage to the tooth or to the restoration that we're going to place over the endodontic therapy. So a root canal treatment is typically something that I use for a tooth that I want to save. It involves removing the entire pulp. It involves sterilization of the canal. So believe it or not, we actually use bleach at 4%. We fill it with an material known as gutta percha, which is derived from a tree, and then we restore the crown. So the benefits are tooth preservation. It's also less invasive. In some cases, say for example, if we're trying to extract a large mandibular canine in a very old dog that has ankylosis, arguably it takes less time to do a root canal than it takes to extract the tooth. The longest extraction I've ever done was probably 2.5 hours to extract a mandibular canine in a staffy with ankylosis, and I can tell you I can do a root canal of a mandibular canine faster than that these days. The disadvantages are that it's a longer anesthetic. Obviously, there's an increased cost because of specialized materials and because oftentimes the anesthesia is longer. And we typically need to perform follow-up in terms of radiographic follow-up. We need to see them again in about 6 months is what's recommended. And then typically every year thereafter to check the success of the root canal. So what is the success rate? The success rate's generally pretty good in both cats and dogs. So in dogs, it's about 95%, and in cats, it's about 81%. And the definition of success here is a little bit hazy. So what you're looking for true success is you're looking for a reduction in the size of the periapical lucency, or you're looking for a periapical lucency that's not getting any larger. If the periapical lucency is not getting any larger, it's defined as no evidence of failure. So what these studies have done is these studies have actually added those two figures together to get the 95 and the 81%. So the second endodontic therapy is a vital pulp therapy. And what this involves removal of 5 millimeters of pulp. And the reason for that is because you're trying to actually remove the contaminated pulp. So you're removing the bacterial contamination. What we typically do is we typically put a thin layer of mineral trioxide aggregate, or MTA, and the purpose of that is to actually preserve the vitality of the tooth, and then we restore the crown. So the benefits are it preserves tooth vitality. It's a short, quick procedure. It's similar in cost to an extraction, at least here anyway. The disadvantages are that it has a lower success rate than a root canal. Not really that low, but it's a little bit lower than a root canal. And we typically recommend follow-up, again, just like a root canal. The success rate for these guys ranges from about 85 to 88%. And if you actually have a look at these figures, especially on the left, which was performed by our very own David Clark, and he was the second specialist in dentistry to be boarded in Australia. If you actually have a look at that figure, the 88% success rate is based on a vital pulp therapy being performed within 48 hours of a fracture. If we look at a week after fracture, it's only 41%, and 3 weeks after fracture, success rate's only 23%. So this is where the whole, hey, if you want to get the dog down within 48 hours, we can perform a vital pulp therapy. This is where that 48-hour period comes from. In a more recent study by Nina Luotonen, we found that the success rate was about 85%, and all these were typically performed within 48 hours. So we know that the success rate's about 85 to 88%. The other treatment option is obviously extraction. I'm sure you guys all know the advantages by now and the disadvantages. The other thing that I would like to take note of is you've got to be careful about extracting a maxillary canine in a cat. Sometimes when we extract the maxillary canine, what the lip tends to do is the lip tends to sink inwards a little bit, and the cat ends up biting that lip, which may eventually mean that the mandibular canine needs to be extracted. So if it's a cat, and we're talking about a maxillary canine, I try and say to the client, look, if you can perform a root canal treatment, do so, and that might stave off potential complications later down the track. As you all know, when we're talking about large teeth, such as the mandibular first molar and the mandibular canine, we always kind of worry about jaw fracture, and that's still a possibility. It's low, but it's definitely possible, and it can be, and small dogs, particularly toy breed dogs, are particularly prone because they don't have a lot of mandibular bone stock. Lastly, odontoplasty and dentin bonding. This is something that we do with minor fractures, so ones that don't involve the pulp cavity, ones that don't have any periapical lucencies. So what we do is we actually smoothen the sharp fracture edges, and this is to reduce the potential for trauma to the oral soft tissues. It also minimizes the risk of that fracture surface, that sharp fracture surface catching onto anything else and fracturing more. And then the next thing that we do is we actually put a thin layer of resin. So it's kind of like a very light restoration. And the purpose of that is to actually seal the dentin tubules and reduce sensitivity. It's also a minimally invasive treatment that you can perform fairly quickly. So how do we tie it all together? How do we make decisions? As I mentioned previously, you have to take a lot of things into account, and one of those is the teeth that are involved. So this is where we talk about the concept of strategic teeth, which are structurally and functionally important teeth. And in the dog, they tend to be the canines as well as the carnassials. And in the cat, we're just pretty much talking about the canines alone. They also have some effect on cosmetic appearance. The mandibular canine, for example, holds the tongue in the mouth. And the maxillary canine, where we talked about lip entrapment, and that occurs because the maxillary canine actually helps to hold the upper lip outwards as well. So we consider these strategic teeth priorities for preservation. So what do we do? So I'm just going to move Zoe so that you can see the rest of it. Okay. So that when you have fractured tooth, the three questions I'd like you to ask yourselves are, is the pulp exposed? Is the root involved? So is the fracture subgingival? And lastly, is there periodontal pocketing? So if the pulp is exposed and we have a young patient that's less than 18 months old, and if you've got a tooth that is a fracture that is less than 48 hours old, what I would recommend doing is I would recommend a vital pulp therapy. Vital pulp therapy. These have actually been switched around. So if it's less than 48 hours and if it's less than 18 months old, we should be performing a vital pulp therapy. If it's older than that, we should be performing a root canal or extraction tooth. So if there's no pulp exposure, the next thing you should ask yourself is, do you see a pink tinge? If you see a pink tinge, that usually means that it's within 1 to 2 millimeters of the pulp. So if that happens, I would recommend a vital pulp therapy. If the client can't afford a vital pulp therapy, then may consider monitoring the tooth radiographically, but there is a reasonable likelihood that that tooth will die. And if there is no pink tinge visible, ask yourself, the area of exposed dentin, is that large? If the area is large and it's a relatively fresh fracture, I would recommend odontoplasty and dentin bonding and monitoring that tooth radiographically. If the area is small, then you could do dentin bonding, or oftentimes if the client's unwilling to pursue treatment, I usually say, oh, look, it's unlikely to be a major problem, but if you can radiographically monitor the tooth later down the track, I would do that. Next question, is the fracture subgingival? If the fracture is subgingival, then we need to do a crown lengthening procedure. So a crown lengthening procedure is where we remove we essentially make the crown longer so that that fracture is no longer subgingival. And the reason why we do that is the fracture site is going to be a plaque retentive surface, and that can result in gum disease. So you should be really doing that with all those slab fractures that extend underneath the gum. And then if the pulp's exposed as well, you need to be doing a root canal. So the patient might need 2 separate procedures. And lastly, ask yourself, is there any periodontal pocketing? Because if there is periodontal pocketing, then what we really should be doing is we should be treating that as well. And we treat that typically independently of the exposed pulp. And this is a little bit easier. Discolored teeth. If we have a discolored tooth, if the size of the discolored area is large, and it typically starts at the very tip of the crown and works its way sort of down towards the base of the crown. So if it's just the very tip of the crown, I'm usually not too concerned. I recommend a dental radiograph, and if there's no evidence of periapical lucencies, then I will monitor that. And what I'll look is I'll actually look at the state of the discoloration. And what we want to see is we want to see a really light pink discoloration. However, if the discoloration is a large area and it's a purple or a gray discoloration, then it's very likely that that tooth is dead. I would recommend a root canal or an extraction.